Immunologic emergencies. The area of immunology that we're going to discuss in this course focuses on allergic reactions ranging from mild allergic reactions to life-threatening emergency allergic reactions. Crucial that you're able to recognize particularly an anaphylactic reaction, but any allergic reaction quickly, and that you anticipate what can happen with your patient. You know what to watch for. You know how to treat your patient's symptoms and when, and that you don't ever get behind the curve in your treatment, because these patients can deteriorate rapidly if you get too aggressive with your treatment too early. Let's say somebody they ate some shellfish and 30 minutes later they have a few hives on their arms. If you jump in and you treat them with their EpiPen, you can cause serious life-threatening issues for them. If you are afraid to treat with their EpiPen and you wait too long and they have cardiovascular collapse, it may be too late. They may be in anaphylactic shock and they're in irreversible shock, and there's nothing that can be done for them. So hopefully after we work our way through this, plus have the lab that we'll have this coming Tuesday, you'll feel comfortable in recognizing these issues and dealing with them quickly and appropriately, and your patients will be all the better for it. What are the problems with acute allergic reactions? What does that do to our patients? What is going to kill our patients when they have an anaphylactic reaction? Acute airway obstruction. They have massive bronchodilation, secretions in the bronchi are increased as the body tries to push allergens out, and that occludes airways, massive swelling of the tongue, the face. We call that angioedema. We have a pretty impressive picture of that here in a few minutes. That causes acute airway obstruction and then cardiovascular collapse. Anaphylaxis that progresses to anaphylactic shock causes massive vasodilation. And that massive vasodilation, remember that perfusion triangle that we've talked about since fairly early on in the course. To maintain perfusion, we have to have a functioning pump, properly functioning pump. We have to have fluid or blood in the system, adequate fluid, and we have to have properly functioning pipes, meaning that we have pipes that are not only intact but also react appropriately. They vasoconstrict and vasodilate as needed by the body. In the case of cardiovascular collapse due to anaphylactic shock, the pump's still working. We still early on have the full amount of fluid. We'll talk in a few minutes about how we start to have some volume decrease, but that's not significant early on. Our patient's problem when they're in anaphylactic shock is that massive systemic vasodilation that drops the pressure because there's not enough fluid to fill up the space. So blood pressure drops dramatically, and that can happen like boom right now. And when that happens, your patient goes from perfusing to I can't perfuse because I can't maintain pressure. If you'll remember, and this is at the next level that we really talk about mean arterial pressure, but that MAP, that all important maintaining a mean arterial pressure of 60 millimeters mercury, at least to perfuse vital organs, that goes in the dumper. And that MAP of 60 is not maintained. That systolic blood pressure of 90 is what we use as a benchmark at the EMT level. Why do I talk about MAP? I want to start getting that in your head. So when you come back to advanced EMT class with us, you're already thinking about MAP. When you see perfusion decreasing, you're already thinking, what is the problem? Where is that perfusion calculation? So 90 systolic is good enough for now. Give you a little preview of cool stuff we'll do down the road. Shoot, that's flight medic stuff. You start thinking about flight medic stuff, you're doing extra good at the EMT level. But what happens when systolic pressure is below 90? We have that roughly accurate, but not entirely accurate rule of thumb that it takes systolic pressure of 90 millimeters mercury to generate a radial pulse in an adult. And what are we thinking if we don't find that radial pulse? Well, the pressure's below 90. Okay, I'll give you that. I'll put that one on the tee for you to whack down the middle of the fairway. What does that trigger in our brains immediately if that radial pulse isn't there? Our patient may not be perfusing their kidneys, and that is a crucial thing. So that's where our patient's headed with this cardiovascular collapse. At the same time, this massive overreaction by the immune system causes capillary beds to become leaky. So our patient starts to lose vascular volume that leaks out through those permeable capillary beds into the surrounding tissue. We call that third spacing. And with third spacing, we lose volume. So now, as this condition progresses, we start to see that fluid leg of our perfusion triangle start to suffer. So they are losing volume. What causes that swelling that you see? A lot of that swelling that you see is that fluid loss at third spacing, the fluid moving into the extracellular space. So let's move through some of this. I got ahead a little bit, as I always do. Let's see what the next slide says. Maybe it has something to do with what we're talking about. We have to be able to distinguish between a localized allergic reaction, which would be localized swelling at for instance, if our patient is stung by a bee or a wasp, that is going to cause localized swelling in the area of that sting. In most people, that's going to hurt, it's going to swell, it will feel warm, but it doesn't cause a systemic problem. Have a localized problem, that's not a life threat. We'll see some percentages later in the lecture, but almost everybody's going to do fine with that, other than they're going to have pain. Maybe all we need to do is, if it's a bee that leaves behind a stinger, we need to use a credit card or driver's license, something like that, to scrape that stinger and remove it from the skin, wash it with soap and water, maybe put some ice on it, and that patient's going to do fine. In 10-ish% of the population, they may be allergic to, no, that's lower than that. I'm sorry. Anyway, we'll wait till we see numbers before we quote numbers, buddy. How about that? In that small percentage of the population, I'm included in that small percentage of the population, we are horribly allergic to bee and wasp stings. And once our immune system is exposed to that allergen, and our immune system memorizes that antigen and prepares to react to it in the future. That's how the immune system works when it's functioning in a healthy manner. Subsequent exposure causes a massive overreaction by the immune system. That's where these anaphylactic reactions come from. In that small percentage of the population who are allergic to bee and wasp stings, that subsequent exposure causes this massive overreaction that we call an anaphylactic reaction, that can lead to anaphylactic shock and death, airway obstruction and death. They go hand in hand. We'll talk more about that in a couple of minutes. So we have to distinguish between the two. If we have a patient who has a localized reaction, we need to watch for that progression and be prepared to treat that. So we'll spend time on that in a minute. What's the function of the immune system? Going back to that human body chapter, function of the immune system is to protect the body against invaders, right? Foreign substances and organisms. So just thinking about something that's in the news too much right now, this COVID-19 stuff, that patients with healthy immune systems fare much better if they contract this COVID-19 virus or any other virus. But with this COVID-19 virus, who are we trying to protect the most, or who should we be trying to protect the most? Immunocompromised people, people with underlying other comorbidities, other underlying medical conditions. But that immunocompromised population has to be protected. Why? Because their immune system does not do its job well enough, and that can lead to death in an instance when somebody should just maybe even just become slightly ill. Their immune system deals with whatever the invader is, and the patient goes on and life is great again. So let's talk quickly about what happens with in the immune system, how that plays in a healthy immune system, and then what happens with these allergic reactions we're talking about today. Again, an allergic reaction is it's an immune system that's a drama queen, right? It just overreacts. You just get a little exposure. It's just a dadgum little bee sting. It's just a couple of peanuts. It's a few shellfish, and this drama queen immune system has to fire up and treat this as if it's a massive invasion from our northern border by Canada coming in to take over the United States, when just a couple of guys coming across they want to go to a coffee shop in Maine, and this immune system treats it like that we're being invaded, and that causes systemic severe problems that can be lethal. The problem is not the bee or wasp sting. It's not the pecans or the peanuts that the kid ate at school. The problem is not that penicillin tablet that our patient took. It's that is a trigger, but that's not the direct problem. The problem is the body's overreaction. It's the drama queen coming out and causing problems. All of us know people like that. So let's just think of the immune system as that drama queen here, and maybe that helps a little bit with this. Or I just made up something that's ridiculous, which has happened before. So what happens? The immune system releases histamine and leukotrienes to combat this stimulus, that penicillin tablet that our patient's allergic to, and it releases massive amounts of histamines and leukotrienes, and that's what leads to the signs and symptoms that our patients see. Fortunately, in EMT class, we don't have to memorize all of the histamines involved. We don't have to memorize what's triggering what and where to the extent we do in the advanced class. Not that it's hard, but you have enough to deal with, right? You don't need unnecessary stuff. So what is that first exposure? We call that sensitization. What happens there? Our immune systems constantly memorize antigens or allergens that we're exposed to, and we call that sensitization. There's a list of things. What does it boil down to? The basophils are part of white blood cells, and the mast cells, M-A-S-T, the mast cells memorize substance that we're exposed to. And then we move on. That's sensitization. Is there a problem then? Very, very rarely. There are extremely rare cases of somebody being so allergic to something that first exposure causes a significant reaction. Just know that exists, push it aside. Think of sensitization as the immune system given the first bite for free. The immune system then chemically learns to recognize that allergen in the future, and when that allergen is recognized, the immune system responds. Normally, that just appropriately deals with an invader. Why did you have to get all of these stinking immunizations up to date in order to be able to go to clinical in this class? So that your immune system is properly programmed and on alert, so that if you had an exposure to measles, hepatitis B, chickenpox while you were doing clinical, your immune system would see that invader, and your immune system would respond to that and attack it, wipe it out, and you go on without becoming ill. Our bodies do that all day, every day. That is the appropriate response. the inappropriate response would be the overreaction. Also, in people who have allergies to, you pick the antigen, you pick honeybee venom to nuts to shellfish to medications. Usually each subsequent exposure causes a more severe reaction. So if you get a patient history and your patient is, say they were stung by a bee, and you respond, you arrive on scene, they have some hives, they're starting to have some wheezing when you auscultate their chest, and they have, and that's what you see when you get there, and you start getting your patient history. Are you allergic to anything? Yes. What happened to you today, of course, would be the first question. I got stung by a bee. Have you ever been stung by a bee before? Yes. Looks like you may be having a reaction to this sting. When you were stung before, how does this reaction compare to that one? It seems worse. Last time I just had a bunch of swelling around the area where I was stung and felt slight tightness in my chest, and then it seemed like everything was okay, and I was fine in 20 minutes. So this one is worse than the last and may progress to a life-threatening situation rapidly. So we also have to get a good sample history with our patients. How quickly did they have the reaction in response to the exposure to whatever it is they're telling you that they're allergic to? Some patients don't have any idea what's causing their allergic reaction. They just know they feel bad. And it's up to you to recognize the signs and symptoms of an allergic reaction, and that creates your index of suspicion of the progression of your patient's signs and symptoms, and your preparedness to treat those as they arise. So here is, well, let's hit this first. I think I've said this 5 times now. Anaphylaxis is extreme, life-threatening allergic reaction. It's not localized, it is systemic. It's throughout the body. It can quickly lead to shock and death. So straight from your book in ABCDE format, here's our good old bee, comes along, stings our patient. The antigens contained in that bee's venom trigger a response in the body. So you have the release of those chemical mediators. I mentioned those as histamine and leukotrienes, and then antibodies in your immune system are activated, and that through the mast cells, that's where the memory is stored within the mast cells, and it just explodes, and the immune system goes haywire. So what does that cause? Have bronchoconstriction and vasoconstriction in the lungs. What does that do? Bronchoconstriction decreases tidal volume, right? It decreases the volume of inspired air that makes it down to the alveoli. Vasoconstriction, what the heck? Why are we talking about that? Within the alveoli and the capillary beds, we get vasoconstriction. Well, what does that cause? That decreases alveolar respiration, right? What the oxygen that's making it past those constricted bronchioles is it's getting down into the alveoli, getting down to the capillary beds, and there's vasoconstriction, so blood flow is limited, so respiration is impaired. That we just took a bad situation, made it worse. But wait, there's more. This is like one of those what the heck do you call them? Like the action thriller disaster movies. That's what's playing out here. So we have, boom, the first wave, the lungs. We have a problem with ventilation. We have a problem with respiration. As we move down from the upper portion of the lower airway and make it all the way down into the alveolar sacs, we have a problem all the way down. Then we now simultaneously, because it's not a cascade, simultaneously the heart becomes impaired. We have decreased cardiac output, and we have decreased coronary blood flow. So we're getting less. Stroke volume has gone down, which decreases cardiac output, because remember, stroke volume times heart rate gives you cardiac output. That would be the number of milliliters per minute being ejected by that left ventricle. So cardiac output is in the crapper. Coronary blood flow is impaired, so we're not getting sufficient blood into the coronary arteries. So perfusion of the myocardium has gone down. And then simultaneously, our patient starts to have massive vasodilation that we mentioned. That massive vasodilation decreases systemic perfusion because there's not enough blood to fill up the pipes being the veins and arteries. Plus, we're losing our patient's third spacing. They're losing plasma into through those leaky capillary beds. They're losing plasma into tissue. So we have two problems going on there simultaneously. What do we see on the skin? We see redness. We see urticaria. That's hives. We'll see pictures in a minute, so you'll understand what hives are. Me describing them isn't enough. We have pictures, and then we see edema, and that edema comes from that third spacing and that leaking fluid from the capillary beds into the skin. So that's what's going on there. Obviously, as you can see from that progression, just take the heart and the blood vessel components of maintaining perfusion, and shock and death our patient can deteriorate into shock and then death very quickly. Hives, the little red bumps, little raised areas. We'll see another picture in a minute of a severe anaphylactic reaction and see a patient covered in hives. Hives have, sometimes you see them develop on the arms and the face. Sometimes you see them in the area of the exposure on the patient. You're more likely to see hives in the area of the sting by an insect, and then spreading systemically with an insect bite, with an ingestion or an injection of a substance that our patient is allergic to. You're more likely to early on see more of a systemic development of hives. There's no magic formula. Uh, hives, urticaria, one of the 3 common signs of anaphylaxis. So burn that into your brain right now. What's gonna cause our ears to perk up and us to pay attention and recognize that our patient may have an allergic reaction that we need to deal with right now, so we don't have a dead patient? Number 1, urticaria or hives. All right. Angioedema. I told you I had a picture of angioedema. Thinking back to CPR, the 2nd and 3rd class sessions of this course, what did we say that the number one, the most common cause of blocked airway in our patients is? Tongue, right? Does it look like from this picture that tongue could be a problem? Hopefully your answer was yes. If you're awake, your answer should have been yes. That is, and this facial swelling you can see somebody, it looks like they went to a 3rd world country to have collagen injections in their lips, and it went bad. They just massively swollen lips, swollen tongue. That's a big problem, right? This patient can definitely have an airway problem. So this facial swelling, the swelling of the tongue, that's angioedema. So we have hives, component 1, right? Sign 1. Angioedema, sign 2. Wheezing, sign 3. Wheezing, it's a high-pitched whistling sound when we auscultate our patient's lung sounds, or auscultate their breath sounds, and you hear, because of that constriction, air is having difficulty flowing through. So it creates kind of a high-pitched whistle sound, and that's wheezing. So if you see those 3 signs, then it's time to get on our horse and pay attention and get aggressive in treating this patient. If you see these things, or if you see angioedema but you don't hear wheezing yet, and you know your patient's allergic to something, you see this angioedema, then call for ALS. This patient needs an IV antihistamine. Normally it's going to be Benadryl. I think that the administration of Benadryl should be an EMT skill. That should be in your bag of golf clubs of pharmacologic agents that you can use as an EMT. But people who write MD and DO after their name, they don't call me and ask what I think. But I think that the benefit of early administration of an antihistamine in conjunction with the nebulized bronchodilator and the administration of epinephrine, that's crucial to our patient's survival, and the benefit far outweighs any risk of you administering Benadryl to a patient. But nobody has followed my suggestion on that yet, so maybe soon. Maybe in the next book they'll decide that I'm right. However, nobody sent me an email and asked what I thought, so the odds of my suggestion being taken to heart might be slim. You could possibly work as an EMT in a rural EMS service, and your medical director says it's crucial with our transport times and even the time it takes to get a helicopter out to remote areas in our jurisdiction. It's crucial that you learn how to administer Benadryl. But for now, that's not within our scope of practice. So how does it become scope of practice appropriate if you have a medical director who approves your administration of Benadryl or an antihistamine to a patient with an allergic reaction. It's appropriate then under the Delegated Practice Act. You're working strictly off of that physician's license. We always are, but this particular doctor would be sticking his neck out and stretching his license out there toward handing it over to the Board of Medical Examiners. The Board of Medical Examiners, reaching out there a little bit further than normal. I don't think it would be a big major deal. Again, nobody asked me. We may also find systemic swelling. We may edema, and start to notice hypotension. If you notice that hypotension, it's time to get epinephrine on board right now. You can't do it without an order. You can assist your patient in patient administration. If you don't have a standing order in a protocol or online medical control, you're stuck. But it's going to be rare that you're not going to have an order to administer this. But remember, for exam purposes, without an order, you can't administer it. I guess you just sit there and watch your patient die while you wait on ALS. But so watch for hypotension. What does that mean? In that primary survey, we have to get a baseline set of vital signs, get somebody going on that immediately, get them to just palpate a pressure for you real quick. And if you get that palpated pressure below 90 and you're seeing hives, angioedema, maybe you're not hearing wheezing yet, but you have hives, angioedema, you have a patient who's having an allergic reaction, and that hypotension is present, we need to get permission to administer epinephrine right now. Okay, other things we're going to watch for: nausea, vomiting, abdominal cramps. Well, why the heck do they have that? As the body tries to respond to this massive vasodilation, and as it suffers from this massive vasodilation, perfusion in the gastrointestinal tract suffers, and when GI tract isn't being perfused, you get nausea, vomiting, and abdominal cramps. Anybody ever have to run a long distance in a PE class and you get that side cramp, that abdominal cramp that goes with, in some people that they suffer that symptom from running a long distance? What's happened is the blood, your sympathetic nervous system has taken that blood that would normally perfuse the GI tract, and it's been moved elsewhere to perfuse your vital organs so that they don't suffer, and that's what can cause that cramping. Don't go swimming until an hour after you've eaten. That's the same principle. Oh, what time is it? Let's go 5 more minutes and we'll take a 5-minute break because I'm sure you need it by now. Okay, some time frames, and this is where I jumped the gun and stated the wrong time frame a couple of minutes ago. Wait till you have the slide in front of you if you can't remember numbers. All right, food. It takes a while to begin to digest and absorb food. That is the reason for this 30-minute delay. Some people have such a violent reaction just ingesting shellfish and nuts at all, just chewing it up and swallowing it and starting to have some absorption triggers an anaphylactic reaction. Shellfish and nuts account for 30% of the deaths from anaphylaxis. That is very significant. That's not a number I'm going to ask you for on an exam. And if I do, tell me, hey, idiot, you said you weren't going to ask us that, so give me credit for that question. I will do that. It's kind of what happened today with the hemophilia A, hemophilia B question. I don't, does it really matter to an EMT or a paramedic whether it's hemophilia A or hemophilia B? No, it doesn't. So that was my bad, because I told you I wouldn't put questions like that on exams. To your credit, several of you got it right. So you've read your book. All right, medications, antibiotics, NSAIDs, all kinds of medications that people can be allergic to. People will tell you they're allergic to a long list of medicines that they don't have an allergy to, such as I'm allergic to codeine. I'm allergic to hydrocodone. What kind of reaction did you have? Is always the follow-up question. It makes me nauseated. It makes me drowsy. Makes my mouth feel real dry. Those are side effects. So allergies to medications are reactions like we're talking about today. Developing hives, developing wheezing, those kinds of things. So a distinction between side effect and an allergy. So people are allergic to numerous medications. Can make it very difficult to treat a patient for a bacterial infection. If they're allergic to several antibiotics, and those happen to be the antibiotics you normally use to treat that bacterial infection, that becomes very difficult to treat your patient. I told you I'd have a big time picture of urticaria that appear to be systemic. I would venture to say that there are very few parts of this person's body that don't have at least some hives. That is a tremendous reaction. If you walk in and you see that patient with hives like that, expect to find a patient who is suffering from anaphylaxis. And a patient who is going to progress to anaphylactic shock and die on you in a hurry. So this would cause you to handle your primary survey very quickly, begin rapid transport, and do all the rest of your assessment and treatment rolling down the road, have ALS rendezvous with you on the way to the hospital, or have a helicopter meet you somewhere along the way. But this is, right now, we've got to do something. Injected medications, that reaction can be, if it's an IV medication, that reaction can be immediate and it can be extreme. You will never forget it when you, after you guys are paramedics, if you ever have the misfortune of a patient not knowing they're allergic to an IV medication you're going to give them, and you administer that medication IV, and that triggers full-blown anaphylaxis, you will never forget that. And what do we call that? That's a butt pucker moment. The old sphincter will not relax for days after that. I promise you. Hope you never see that. It's a bad feeling. All right. Ingested medications. Why the 30 minutes? What's magic about this 30 minutes? Is it always 30 minutes? No, it depends on how long it takes for our patient to start to metabolize the medication, start to absorb that medication. Where is that medication primarily absorbed? If it's primarily absorbed in the duodenum, then you have to wait for that ingested medication to break down and to clear the stomach and move into the duodenum before you're going to start seeing absorption and reaction. So that 30 minutes is just a rough number. Maybe your patient has very slow gastric motility, so maybe they take a a lot of opiates for pain management, and that causes things to move very slowly through their digestive tract. So it takes an hour before they begin to have a reaction to a medication they're allergic to. So that's the reason for the delay. Let's take 5 minutes, catch our breath. I'll try to get a drink so my scratchy throat from allergies will quit being your problem, and we'll keep on going. Questions before we take a break? Everybody good?
Good.
All right. Other common allergens: dust, pollens, ragweed, ryegrass, maple, Bermuda grass. Long list of plants, right? That's so. What kinds of problems do those cause? Oh, it could just be allergic rhinitis, like hay fever, watery eyes, runny nose, excessive production of mucus, that kind of thing. There are people who have significant enough plant allergies that exposure could trigger an anaphylactic reaction. That would be more rare with a plant than, for instance, an injected or ingested medication or food. Plants seem to most likely cause even somebody with an extensive allergy, a severe allergy to a plant. They're more likely to have more of what I call a violent localized reaction. It gets really red, it gets swollen. Maybe they do have a few hives, but then it starts to resolve itself. Or most people with that kind of allergy to a plant will carry an antihistamine with them and clean it and use a topical antihistamine and maybe even an oral antihistamine. Things like, some people are really allergic to the pollen from cottonwoods, that cotton that floats through our neighborhoods and inundates us with this snowy looking allergen that makes us feel horrible, and we go get a steroid shot, which chills out our immune system. That's the purpose of that corticosteroid, calm down the immune system. Then chemicals, hair dye. That's what happened to my hair, right? Made my hair fall. No, that's not what it does. Makeup, soap, hair dye. One that we found, as I've told you probably too many times now, that back in the dark ages when I first hit the streets in EMS, we wore gloves for very few things. We wore gloves for sterile procedures and delivering babies, and the rest, you just washed your hands really well afterward. But as HIV swept across our great nation, fortunately, hospitals, ambulance services, healthcare institutions thought it wise that we begin wearing exam gloves for patient contact. And early on, almost all of those gloves were latex. What we found was people wearing those latex gloves, some people were horribly allergic to those latex gloves. I have a friend, excellent nurse, used to be my boss when I first started working at the health department, and she was a critical care nurse with probably almost 20 years experience when they started wearing gloves all day. So she was exposed to latex all day, every day, and it reached the point that she was having a significant enough allergic reaction that it moved past localized just the hands where her hands were in those gloves to a systemic reaction, and her doctor was concerned that it could be the next exposure, or it could be 100 later or 1,000 later, but that it was going to trigger anaphylactic shock and she was going to die. So the hospital kindly moved her up into a management position so that she didn't have patient contact anymore. And she's one of those nurses that would love to be a bedside direct patient care nurse for 50 years and hang it up and call it a retirement. But that latex allergy moved her into management. She excelled at that, like everything else she's done. So when nitrile gloves came along, which is what most of the gloves that you'll see now, when those came along, she didn't go back to bedside nursing, but boy, she still misses it all the time. All right, history lesson, right? Okay. Now you know me well enough to know that I have a story for everything. I try to use those appropriately. That was a big deal. That pushed clinicians out of medicine who had been in medicine for many, many years, and they didn't come back when gloves evolved and they were made of a different material. Okay. Do all insect bites and stings cause an allergic reaction in patients who are people who are allergic to those particular insect bites and stings? No, it requires envenomation. That is just the process. Just picture that honeybee with all of that venom stored up and that stinger sticking out ready to go defend the queen, and that little barb, that hollow tube, is injected into the skin. If there's a malfunction and that, I don't know what it's even called, the structure, the reservoir for that venom that honeybee carries, if that isn't injected, you don't have envenomation and you won't have the allergic reaction, as far as I know. I mentioned it already, you can have localized reaction, that's the swelling and itching, that may be the end of it, or systemic reaction, which is normally progressive, and the signs and symptoms worsen. It may be very rapidly that they develop, but eventually that moves to the point that it involves the patient's entire body. I told you I was wrong on my numbers earlier. 3% of adults, 1% of kiddos allergic to the venom of bees, wasps, and hornets. I didn't have to find out the hard way. I had been stung by a bee before and by wasps, never by a hornet, but I had the old allergy testing where they draw a grid on your back and they take little bits of, or little bitty pinpricks of various substances to see how you react. And I had a major reaction to bee and wasp venom, so I carry an EpiPen. All right. You would think that, let's see, 30 million, anyway, you would, or 300 million adults or people in the 340 million people in the US, you would think that, and 3% of adults allergic, you would think that more than 50 people per year would die in the US from allergic reactions to stings. I think that's great news that if that statistic is accurate, that it's 50 deaths per year. Maybe that's because of really good EMS care. Maybe that'd be thousands, but we snatch all but 50 from the jaws of death every year. That's a good deal for us, right? And you talk about feeling like you got to make a major difference and really save a life. If you treat a patient who is in anaphylaxis and you treat them appropriately and they respond to your treatment, you really do feel like you've done something. We don't get that feeling all that often. Okay, we already talked about what the stinger is and how venom is injected. In my question bank that I pull from, there's a question about how many times a honeybee can sting you and how many times wasps and hornets can sting you. What's important about, why is that even in your book? Because the honeybee stings you once, he flies away and dies. He gave his life for his queen, because that's why they sting you, is to protect their queen. Something that happens that can cause multiple exposures when a honeybee stings, or when a wasp or a hornet stings, pheromones are released that other creatures, like the one who just nailed somebody with their stinger, those other creatures pick up on those pheromones and then they swarm to the rescue. So you could receive multiple honeybee stings because the pheromones are sensed by the other soldiers, and they come to fight the battle as well. And if you're the invader and those pheromones are emanating from you, you may have multiple exposures. If your patient if they're allergic and you respond and you know they're allergic and they have multiple bites or stings, that should cause you to get up and go a little bit faster and watch for an even more rapid development of signs and symptoms in your patient, because they have multiple exposures, and maybe they're that person who would eventually go into anaphylactic shock from the sting of one honeybee, but they have 25 stings. That is something we need to deal with right now. Wasps and hornets, they can just keep nailing you. So you can get into we call them yellow jackets around here, have a wasp nest, a yellow jacket nest on the side of your house, and you decide you're going to take a broom and use that broom and knock that thing down, and those little demons come swarming out of that hive, and they can just sit there and sting over and over and over. So a patient, you can have a patient who has multiple exposures from the same wasp or hornet. More likely there will be others in the area, and they'll have multiple stings from multiple insects, and that can create a horrible situation for your patient. Those are fire ant bites, and I guess it's a matter of time till we have fire ants in Amarillo, Texas. As far as I know, we do not yet have the misfortune of having fire ants. I have had the unfortunate occasion to move to some place that had fire ants, and I had never heard of fire ants. And there was this little mound of dirt in the yard the first time I mowed the yard. I didn't know I mowed right into the fire ants, and they hate you for it, and they will bite and sting the heck out of you. Apparently I'm not allergic to those. I'm still here. But that is what what you see, it almost a little pustule looking bite from those guys. This thing right here, this little raised area is called a wheal, W-H-E-A-L. It's in the area of the bite or the injection of the envenomation from the bite. Used to call those whelts, I think. And then they came up with wheal because I guess welt sounds not nice. Wheal must be the politically correct term for welt, I guess. It's not a big deal. Know what a wheal is. What are signs and symptoms with an insect sting? We probably all already know this from possibly even some personal experience for almost all of us. Sudden pain, swelling, localized heat. That's warm to the touch. Urticaria. Now we're getting worse, right? We have those hives breaking out. Redness in the area of the bite in light-skinned people. And then severe itching from that histamine reaction. And then that wheal popping up there. Some people wash it off, put ice on it, and they will be fine. Some people, we need to worry about that after we've dealt with life threats. So let's talk about the severe reaction. That's what do we see with that? We see probably all of these signs and symptoms in our list over here. And that reaction progresses to being that drama queen, violent immune system reaction to that antigen. Our patient starts to have bronchospasm and wheezing. They start to feel chest tightness. They start coughing. What's happening? Their body's trying to get rid of this invader, and it's engaging all of its resources to try to do that. Patient becomes dyspneic. I guess so. If earlier we talked about not only the bronchospasm, but we talked about vasoconstriction in the capillary beds and the alveoli. Obviously, that patient is going to be very dyspneic, and they're going to feel very anxious. Where does the anxiety come from, other than I know I'm allergic to these devils and one of them just nailed me? That starts to engage my sympathetic nervous system. But where does the anxiety come from? Part of that anxiety eventually comes from decreasing perfusion to the brain, because we've talked about cerebral hypoxemia causing, or ischemia, same thing, causing agitation, anxiety, even combativeness. So you could see all of those things, and that goes partially with my fear of I've just been exposed to this thing, to that hypoxia developing and causing those signs in my patient. And they may be telling you, I feel like I'm going to die. I'm going to die. Don't let me die. I'm going to do everything I can for you. That's not real reassuring until you actually start treating that patient and they start to feel some improvement. Then they might believe you if you tell them I'm doing everything I can and I'm going to do everything I can to keep that from happening. Don't ever promise a patient that they're not going to die. Bad move, because sometimes they do. That's any patient, not just these patients. And then the gastrointestinal complaints, we talked about why that was earlier, why the nausea, vomiting, abdominal cramps, and then eventually hypotension. That eventually could be very shortly, or it could be minutes, tens of minutes from now, but it may develop. Patients could quickly develop respiratory failure. Uh, what are our clues going to be that our patient is not in respiratory distress? They have progressed past that to respiratory failure. What have we talked about all semester? It's no different now. If you have signs and symptoms of dyspnea, if your patient has dyspnea with signs and symptoms of poor perfusion, we're going to treat that patient as if they're in respiratory failure. Well, what in the heck do we do for that? Do we punt? No, we use positive pressure ventilation. We're going to get our good old bag valve mask, and we're going to bag assist their ventilations with 100% O2 in an adult at 10 to 12 per minute. And while we're simultaneously treating the cause, which would be the anaphylactic reaction that our patient is experiencing, but that is positive pressure ventilation is the treatment for respiratory failure. Always remember with your patients or on the national registry or on my exams, respiratory failure is, so dyspnea, what do we see there? Either the respirations are too rapid, they're too slow, they're too shallow, or our patient has one of the breathing patterns that is indicative of a problem. So that's what we're talking about with the dyspnea, plus poor perfusion. That can be altered mental status. With dyspnea, we're going to treat it as respiratory failure. That could be that our patient has extremely rapid respiratory rate and they're hypotensive. We're going to treat that as if they have respiratory failure. Plus, we're going to manage the circulatory component to the best of our ability. But that's what we're talking about on respiratory failure. So anaphylactic reaction can lead to death quickly. How quickly? Your book says over 2/3 of patients who die from anaphylaxis do so within the first 30 minutes. That's quick. How long does it take us, quite often, how long does it take us to respond to a scene? We're going to say between 6 and 10 minutes, depending on your jurisdiction, the number of responding vehicles on the streets. Is it a rural area? Is it an urban area? All of those factors. It can take us an average of 6 to 10 minutes to arrive on scene. Well, shoot, there's 1/3 of that time gone, right? Oh, it's worse than that because EMS had to be activated for us to be dispatched. So they may have wasted 5 or 10 minutes before they call us. Oh man, maybe 2/3 of our 30 minutes is gone now. See why we say you have to recognize this and treat this quickly? Now we have 10 minutes. Well, that platinum 10, we kind of program in our heads in EMS. Well, if we can be off scene and transporting our patient headed to the hospital within 10 minutes, boy, we deserve like a gold star for the day. We have been excellent EMTs and paramedics for the day. If we can maintain an average of that platinum 10 across the board, we're doing great. But wait, now we've burned 30 minutes. We've burned our entire 30 minutes and we're just now leaving the scene. So we have to respond, recognize, treat life threats, get on the road, call for ALS to rendezvous with us, call for a helicopter, do our assessment and treatment en route, provide the life-saving treatment quickly, early on in this thing, so we can push the Grim Reaper back, right? We can push it back past that 30 minutes. So that's the importance of recognizing this and getting on the stick. That's also the importance of maintaining short response times. So and you always see them, the people, especially with system status management like they have in Amarillo, where they're in the trucks all the time, that for the most part, they're in the vehicle and ready to go. But let's say say you work in Canyon at VSA EMS and you have a station and you get the call and put your boots on, you put your shirt on and get it all squared away. You tuck it in so you're looking sharp and you're Mr. Cool. You don't get excited and hurry about anything because I got this. So you stroll out to the truck and you don't get on the radio and say, Life 6 is 10-8 ready to copy, and they give you the call. You get on the radio and you say, Amarillo Life 6, we're 10-8 in service and we're ready to copy. And they give you the address, and then maybe it's the old days where you don't have a computer screen in front of you and you say, 10-4 copy, we'll be en route, code 3 to 3400 West 34th, and then you're off. But you're not really, because you're a smoker and you need to get a couple of drags of your cigarette. So you've put yourself en route to this call, and then you stick your head back out and you suck down half of a cigarette. Then you get in the truck and go. You're dealing with somebody's life. Minutes can be it can be a killer. So move with professional expedience. Don't run and sprain your ankle and get hurt and cause response time to be much longer because the closest truck is now out of service. But what do we call it? Move with professional expediency. You walk quickly and you copy your call, you get on the road. I think you can see now why not goofing around can be the difference between life and death. Let's talk about treatment. We're going to run through it, and then we're going to hit it in more detail as we work through the rest of this. We need to get oxygen going via non-rebreather mask, like boom, right now. Positive pressure ventilation, if indicated. When is that indicated? If they present with possible respiratory failure. When is that? If the rate, rhythm, or depth of respirations is outside normal. So if your patient is dyspneic plus signs and symptoms of poor perfusion, then we're going to get on the stick with positive pressure ventilation. We're going to bag assist their ventilations with the bag valve mask, and we need with 100% O2. That requires telling your patient what you're doing for them and getting them to trust you so that they relax. Because if you're in distress and somebody slams a mask over your face and they start holding it there, they might as well have a pillow over your face smothering you to death, right? So you're already not perfusing your brain well, and then somebody's trying to smother you. So we have to try to explain to them what we're doing, why we're doing it, and you may have to reassure them frequently that you're doing exactly what they need at the moment. Can also use just left my head. Somebody help me. CPAP. You can also use CPAP if your patient is conscious and can follow directions. What else would that CPAP do for that vascular permeability that could be filling up the alveolar space with fluid and causing pulmonary edema? We can force that out of the alveoli, which increases alveolar respiration. So positive pressure ventilation could, if they have wet lung sounds, if they're developing pulmonary edema in the middle of this anaphylactic reaction, then move to your positive pressure ventilation. And rapid transport, why did I move that up to almost the top rather than down at the bottom, that 30 minutes we just talked about, we can begin rapid transport. We can call for ALS, and we can be on the road. So we start positive pressure ventilation, or get oxygen via non-rebreather going, get a baseline set of vitals. We're on the road and doing everything else on the way. ALS can meet us somewhere along the way, but we're going to do our thing. And part of that involves removing the stinger or causative agent. That don't grab tweezers and squeeze that stinger. You just squirted the venom that was inside that stinger into your patient. You injected more and you've made the problem worse. You just take the edge of a credit card or a driver's license and just scrape, and that will scrape that barb called stinger right out. And then we'll learn to do this in lab next week, but get somebody rolling with your with bronchodilator via handheld nebulizer. And quite often that's going to be albuterol and Atrovent together. We will teach you why in lab next week that we use both. Those are bronchodilators, and the synergistic effect, the combined effect of those two make a tremendously good bronchodilator for our patients, whether they're have an exacerbation of COPD or whether they're having an anaphylactic reaction. So we'll talk about that in detail in lab. We're going to keep rolling here. Quickly, if you have an order to do so, we're going to move to either using our patient's EpiPen or ours. Those things are expensive. So it may be that you have a protocol that includes having you use a syringe and needle and draw up 0.3 milliliters, which would be 0.3 milligrams, 0.3 milliliters or 0.3 milligrams. That leading zero is important. Of epi, 1 to 1,000. What is that? That's a concentration. So that's a ratio. And that's 0.3 milligrams is the adult dosage. For kiddos, it's 0.15, or using an Epi Junior. And we'll teach you to do those things in lab. We'll teach you how to draw up Epi. We'll teach you how to administer that Epi. And then we can repeat with an order if our patient, because the body metabolizes epinephrine quickly. So you can administer Epi, you can repeat the administration every 5 minutes. That's what that Q5 minutes, Q5 for a maximum of 2 additional dosages. So your patient could get a total of 3 doses of epinephrine if that's what's required to maintain your patient. How do you know whether you need to administer those subsequent doses? You reassess your patient. You're always reassessing your interventions, and the administration of epinephrine is obviously an intervention. Transport your patient in the shock position. That would be supine in this instance. And prior to that, that patient is not going to be comfortable. If they're not in shock, they're not going to be comfortable in the shock position. They are going to prefer to be in the high Fowler's or semi-Fowler's position, either head up 45 degrees or even almost straight up and down at 90 degrees. They may pull themselves up to that position if you don't raise the head of your cot to that position. Okay, now let's back up and run through the whole sequence. Just remember your patient assessment algorithm as we go through this. If you happen to have it written down and in front of you, You can follow along and see what we're doing here. Scene size up. Are there still bees and wasps and hornets swarming everywhere? If so, I'm going to tell you, bring my patient to me. That's because we don't need a responder on the scene being me having an anaphylactic reaction in the middle of our patient's anaphylactic reaction. Okay. Size up that scene. That may give you a good idea of the source of the reaction. If your patient is at Red Lobster and they have a half-eaten platter of seafood in front of them and they've developed angioedema and hives and you're called, then you more than likely have a food anaphylactic reaction. Maybe there are no clues when you approach the scene, except for you see a pill bottle on the table and your patient is having an allergic reaction. Are you on a new medication? Have they changed your medication up recently? What is it? How many times have you taken it? It will in all likelihood be more than once. Okay. Don't blow off other possible causes of respiratory distress. It could be that maybe your patient was stung by a bee and they're allergic to a bee, but there was no envenomation and they have signs and symptoms of respiratory distress, but they don't have hives, they don't have angioedema, they don't seem to be having a perfusion problem, but they're wheezing, they're tachypnic, and your sample history, when we ask about past pertinent medical history, what would be appropriate to dig into there? Do you have a history of asthma? Have you ever had an asthma attack? We talked about a couple of weeks ago, I think, triggers for asthma attacks. Stress in some people can trigger an asthma attack, and the stress of the sting, knowing that there's that underlying allergy, may have triggered an asthma attack when there was no envenomation. So your patient stays in that with that respiratory component. They don't have other signs and symptoms. Do we use epi then? No, we're going to stick with our bronchodilator. That's likely to be albuterol and Atrovent. Albuterol is albuterol sulfate, and Atrovent is ipratropium bromide. So we'll play with those in lab next week. Maybe your patient is a construction worker and they're framing up a house. They have the walls framed up and maybe they're setting trusses on the roof, and your patient is walking top plates, setting trusses on the roof, and your patient's stung by a bee and freaks out because she's allergic to bee stings, and that causes her to get excited, lose balance, and fall 30 feet down to the hard ground. You have more problems than just that possible anaphylactic reaction to that bee sting. You have a patient who suffered a fall from a significant height, has probably multi-systems blunt force trauma. That patient can deteriorate much more rapidly than the patient with either the blunt force trauma or the anaphylactic reaction. That patient can't, if that patient has internal bleeding and they're moving toward hypovolemic shock, what does the body do in hypovolemic shock? It compensates with peripheral vasoconstriction. For one thing, well, shoot, a patient has been stung by a bee and they have massive peripheral vasodilation. So that patient can't compensate for shock, and we've compounded the shock problem, and your patient is going to decompensate quickly. So, or maybe your patient suffered the sting and got excited and fell and has blunt force head trauma from striking a coffee table on the way down. All kinds of scenarios. They're unlimited. My imagination is limited. So always follow standard precautions. You have to protect yourself. Early call ALS. That doesn't mean you wait on the scene for them. Think back to that 30-minute time frame that we talked about being the majority of deaths from anaphylaxis happen within 30 minutes. So let's do our primary survey, get a baseline set of vitals, and we're on the road doing everything else, and ALS is meeting us on the way. Why ALS? Why do we need them when we have some pretty cool tricks of our own to use? With calling ALS, we have advanced airway management, including being able to do a surgical airway on that patient with massive angioedema. Paramedic can start an IV and administer fluids to help fill up the container, administer vasoconstrictors to help make that container smaller. So those are some cool tools, and they can give that magic medication that I said, in my opinion, you should be able to give. They can give antihistamines, and the antihistamines block this histamine reaction that's causing the majority of these signs and symptoms. That's the purpose of the antihistamines. They're a blocker. Think back to our pharmacology lecture. Think back to receptors, and now you can picture that antihistamine, that Benadryl molecule coming in and occupying the spaces, those molecules occupying the spaces on these receptors and halting the progression of that anaphylactic reaction. So that's why we need to call ALS. Doesn't mean you need to wait to treat. You need to be all over this, and when it's appropriate, you need to be extremely assertive with this. General impression: is my patient going to die? Or are they not going to die? Are they pretty chilled out, kicked back, everything's looking good? Or do they have that FTD appearance? Are they fixing to die? That's we don't get to use that acronym nationwide. That's just a Southern thing. We're special. We have FTD down here, fixing to die. I guarantee you, in our part of the world, if you have online medical control on your cell phone and you say your patient looks like they're fixing to die, then you're going to get somebody's attention. You may get your tail chewing if that's not the case. And never do these invasive treatments, or any treatment for that matter, just because you know how to do them. That is very poor medicine. That can possibly be lethal to your patient. You treat your patient appropriately. I tell you to be assertive, but don't do things just because you can do them. Some of that comes with experience. Most of us tend to overtreat our patients a little bit early on in our career. That's a natural progression, but doing everything in the list of the protocol just because you have that protocol, we call that cookbook medicine. We want to be thinking clinicians, and we want to We want to be problem solvers and treat our patients appropriately. All right, enough of that sermon. Look for medical alert bracelet, necklace, anything that if your patient's unconscious, it would give you an idea. Or if they're conscious, but they're confused and you can't communicate with them, look for some sort of medical identification tag, bracelet, card, something that would tell you that your patient has a severe allergy to something. It could be that bystanders know. Guys at the park walking his dog and a swarm of wasps attack him. He may have told bystanders, "Oh, good God, call 911. I'm allergic to wasps and I just got stung by all these things." So he may be unconscious, but they may be able to help you out. Get on the stick with trying to maintain your patient's airway. It may be that you see they have an airway problem right off the bat. They won't tolerate an OPA. Let's get an NPA in there and start trying to ventilate these patients. You may only have a minute or two to get that done and ventilate that patient. And having that appropriate length nasopharyngeal airway in there may be what saves your patient's life. That may be what helps them hang on until ALS can get there and possibly even do a surgical airway. So you're never just an EMT. You are a clinician with some amazing skills that you can use to save a life. In a career, you may only see one or two of these, but that's good for your patients. We always want to see a little bit of everything and treat it, but it's just kind of the luck of the draw or the unluck of the draw. Quickly assess for increased work of breathing. What does that look like? Retractures, sitting in the tripod position, use of accessory muscles. Those neck muscles they're straight in those neck muscles, nasal flaring. They're fighting for every breath they take. That's tachypnea. That's increased work of breathing. Use of abdominal muscles. That's an accessory muscle. All of those go with increased work of breathing. You guys did really well in respiratory. I think you understand increased work of breathing, but I have to say it anyway. Head bobbing, that's another one. As they get tired of fighting for breath, as they get tired, they start bobbing their head when they try to breathe. They're getting late in the game of trying to fight here. So, and then adventitious breath sounds, wheezing, and crackles, those kinds of things. Talked about what wheezing is already. Results from contractions of those smooth muscles around the bronchioles, and then you have overproduction of mucus, possibly trying to push out an allergen. At least that's what the body thinks it's trying to do. Very ominous sign is that your patient was wheezing. Now they're barely moving enough air so that you can hear breath sounds, or they have a silent chest. They have the muscles of breathing are working, but you're hearing greatly diminished or absent breath sounds. We're going to teach you next week how to take your nebulizer and incorporate that either into the CPAP or into your bag valve mask, so that with your positive pressure ventilation, you can force the bronchodilator down into those bronchioles to start trying to open that up. And that is what's going to be necessary to treat that that silent chest. Stridor, that's that harsh, high-pitched sound on inspiration. That's obstruction moving toward possibly total obstruction of the upper airway. So that's an upper airway sound. And eventually your patient just gets worn out and stops breathing. And then cardiac arrest follows respiratory arrest pretty shortly. So assist your patient's ventilations. That may be putting CPAP on them, sitting them in a high Fowler's position. They don't have signs of shock yet. Having that high Fowler's position with CPAP, with albuterol and Atrovent incorporated in, pushing that deep down, all the way down into the alveoli to open up their airways. And that, what would be the purpose of the CPAP with say about 10 centimeters of PEEP? That PEEP, remember, that is positive in expiratory pressure. That's that back pressure that keeps the alveoli inflated. So we're keeping the alveoli inflated, and with that positive pressure, we're moving that bronchodilator deep down into our patient's lower airway, and that's going to make a major difference for them respiratory wise. Circulation, patient may either present with hypotension, or as you reassess them, they may become hypotensive. Right off the bat, what have we taught you from the start? You walk up, you grab bilateral radial pulses, you look your patient in the eye, and you ask them a question that they can't answer with one word. And so I would walk up, grab bilateral radial pulses, look them in the eye, say, "Hi, I'm buddy. I'm a paramedic. I'm here to help you. What's going on today?" If they say yes or they say no, that's an inappropriate response to my "what's going on today," right? Or "what happened today." They have to say, "can't breathe, stung by bee, gonna die," whatever they're gonna say, or they can just speak to you like I am right now, not in quite as much distress. But if they tell you, "I'm allergic to bee stings, I got stung on the arm here, look how that's reacting, I'm really concerned," or "I'm scared to death," then that's a more urgent situation, right? You have to fully assess your patient, get that, move through that rapid primary survey quickly. Okay, when you find a life threat, what do? You stop it, you treat it, and you don't move on till you fixed it. So, okay. Indications of poor perfusion, or hypoperfusion is poor perfusion. Rapid pulse rate, cool cyanotic skin, could be red skin from that allergic reaction. They're diaphoretic, they have wet skin, maybe they have delayed capillary refill. What's one of our tools that we use in each set of vital signs with these patients? It's that SpO2 clamp, the SpO2 monitor that goes on the finger. And if they're not perfusing their extremities, that's not going to be accurate, right? So how are we going to determine perfusion? We could use capillary refill. Our patient's mental status is going to be our biggie. That is going to be a major component in assessing circulation and perfusion, right? Always. Treatment, we've gone through this already. We're going to do it again because it's important. Oxygen, either via non-rebreather mask or by positive pressure ventilation. Positioning, are we going to have them seated upright because we're primarily dealing with the respiratory issue right now, or do they have signs and symptoms of shock so that they need to be in that recumbent position, which would be supine? Okay, prevent loss of body heat. Let's keep them warm, and then Here is the biggie. The definitive treatment for anaphylactic shock is epinephrine. We need to administer a pharmacologic agent that is going to cause the therapeutic effect of it is going to be vasoconstriction, peripheral vasoconstriction, and that is epinephrine. Transport decision. Err on the side of caution. Is it dangerous to head to the hospital with lights and siren? Yes. Is it indicated? If the answer is yes, or with these patients, there's a dang good chance, then let's initiate rapid transport of our patients. Take along any medication, your patient's medications. If it doesn't take a bunch of time to get them together, if they're there and handy, take them with you. If it causes a delay, tell somebody to bring it to the hospital when they come to the hospital. All right. And I said it again, I guess. Err on the side of emergency transport. We're firing up the lights and sirens and feeling like we're doing the real deal instead of just driving to the hospital. Even if your patient exhibits very few signs or symptoms of an allergic reaction, but they tell you they're allergic to something they have consumed, injected, or ingested, or something that's been injected into them, like bee or wasp venom, then let's err on the side of caution. Don't be looking for that no transport because you want to get off work and go to your kid's birthday party. Birthday parties are important in our business. We're going to miss a few of them. It's a sad reality of this business, but don't try to talk these patients out of going to the hospital. Don't let your partner try to talk about it going to the hospital. If it causes later on a screaming, yelling fight with your partner, if your partner's trying to talk this patient out of going to the hospital, then it is entirely appropriate to first say, hey, and whisper in their ear, we got to transport this patient because they're allergic and they do have some signs and symptoms and we need to get them to the hospital. And then if they go back to trying to talk them out of it, then I've butted in before and said, hey, look, we need to take you to the hospital. You need to be checked out. This can get worse really fast, and this can cause a life-threatening problem for you. So you really, really need to go to the hospital with us right now. Partner's going to be mad. They may be mad at you for a long time. It may destroy a relationship with a partner. We're not there to be friends with our partners. Most of the time we are going to be. On rare occasion, you will have a partner who will try to talk people out of going to the hospital. And if it's this patient, then it doesn't need to happen. Take it to your supervisor afterward if needed. If you can't resolve it with the conversation after the call, like we're adults, we try to resolve it amongst ourselves if we can, but don't let your patient suffer because of it. Investigate chief complaint, history of present illness, just like always, any associated signs and symptoms. Could our patient also have a cardiac problem because they're having allergic reaction? Yeah, the stress of this allergic reaction, if your patient has an underlying cardiac condition, could trigger them they start having cardiac chest pain, and maybe this sympathetic response causes that they have coronary artery disease, and coronary artery constriction causes them to start to present with signs and symptoms of an MI. So this chart, I'm not going to read it to you. We've been talking about them, but these are the signs and symptoms of an allergic reaction. Don't just memorize these. That's a good thing. Memorize them, that's nice, but know these and be able to incorporate these into your assessment and your patient care. That's when you become a clinician. I mean, I couldn't, but I always say this, I could almost teach my dog over here to memorize the list and perform the monkey skills to maybe be an EMT. I couldn't, but monkey skills. You teach a smart chimpanzee to put oxygen on somebody and go through all these motions. They're smart. They could learn how to do it, and their hands work similar to ours. So maybe they could do a lot of the skills that perform a lot of the skills that we perform. When you become a clinician is when you've developed your critical thinking skills to the point that not only do you know what's on this list, you can recognize it. That makes you immediately think think of the pathophysiology that is taking place in your patient and what treatment is indicated to deal with that pathophysiology. Tables and lists are great, but it's only part of the battle, and it's not easy to memorize a bunch of stuff. That's a lot of work, but I see it semester after semester. Not so much this summer. That's why I'm so impressed with you guys. But semester after semester, I see people who can memorize lists, and they do well on all the questions on my exams that aren't scenarios. And the scenarios just kick their tails, or they make it through EMT class, but they can't ever pass the national registry because they can't manage the scenario questions. Why? Because they haven't developed those critical thinking skills. And I think you guys are much, much better than any class I've had. I'm extremely impressed. So keep up the good work. Sample history. We need to get that sample. When are we doing all this? If our patient is having an anaphylactic reaction, we're doing all this on the road, right? We've done our primary survey. We're dealing with those life-threatening respiratory issues right off the bat, and then we begin that rapid transport. Contact ALS to meet us on the way if we have a long transport time, and then we start in doing this stuff. So in getting that sample history as we're rolling down the road. Oh wait, I mentioned something, and I just popped something in my head. Include with that baseline set of vital signs, take a good listen to your patient's breath sounds, especially before you have a lot of experience doing it. It is tough to auscultate breath sounds bouncing down the road, sirens going, all the noises in the back of an ambulance. It takes practice to reach the point that you're proficient with auscultating breath sounds during transport. So part of your baseline set of vital signs is going to be for you to take a good long listen. Long, what do I mean? Sit there for minutes and listen? No, I'm talking 5 seconds in the right upper chest, left upper. So that takes care of the apices, right? Apex, base, a good 5-10 second listen, if that's what it takes to assess your patient's breath sounds and compare side to side. That is extremely important with these patients. Okay. Get that sample history. That includes what I mentioned earlier. Any past severe allergic reactions. How does this one compare to that? What was done to treat that one? Were you hospitalized? How long were you hospitalized? All that kind of stuff, if they know and remember, and if they're able to engage if they're responsive enough to answer your questions, and that may be iffy at first. Remember, if it's an ingested allergen, that that allergic reaction may, as they continue to absorb more and more of that food that they're allergic to, their reaction may progress and intensify. Also, ask about GI complaints, that nausea, vomiting, and then a good systematic head to toe physical exam. You can do that quickly. We know how to do a rapid trauma assessment. Then focused assessment, watch for further development of hives. Do those things look like they're increasing in number? Do they have a rash that looks like it's getting more and more red? It's looking worse. Is swelling extending? Do they look more swollen than they did before? Look in their mouth. Is that angioedema progressing? Their lips are getting bigger, their tongue's getting larger, their face is starting to really swell because of that third spacing of into the tissue of the face. So watch for those things to progress. Every time we reassess, do a good job of auscultating those breath sounds. What are we looking for? Changes. Is it getting better? Is it getting worse? If we're nebulizing a bronchodilator, are the breath sounds improving with the bronchodilator? No. Oh man, maybe we need to move to positive pressure administration of this bronchodilator with CPAP or BVM. Get that good baseline set of vitals. That would include O2 sats, and unless you're on an ALS ambulance with say a LifePak 12 or a LifePak 15 or one of those more advanced cardiac monitors that has end-tidal CO2, you may not probably aren't going to have that available to you on most BLS trucks, but if you do, remember that end-tidal CO2, that sampling for the carbon dioxide level in that last little bit of expired air, that end-tidal CO2, that gives you the best picture of respiration and perfusion. So 35 to 45 is normal. It could be super low if your patient has massive bronchoconstriction, and with vasoconstriction in those alveolar capillary beds, not much exchange has taken place. So that may go down to the point that maybe your patient has a end-tidal CO2 of 5 or 10. That's not a good sign when 35 to 45 is the millimeters mercury is the normal range. Keep a good eye on patency of their airway. Do that angioedema, their work of breathing, changes in their breath sounds. Q5 reassessment, we say 5 and 15, 5 for unstable, 15 for stable. I'm going to tell you that with a patient having an anaphylactic reaction, even if they don't appear to be in distress yet, I want you reassessing them at least every 5 minutes, because they can deteriorate rapidly, and a whole lot, too much can happen in that 5-minute span. So I'm at 15-minute span. So go ahead and reassess every 5 minutes. I think would be really good if you're able to do it. On a test or on the national registry, if they're stable, then your minimum time for reassessment is Q15 minutes. I'm telling you what I think would be best for you to do as a clinician taking care of patients in the field. So don't confuse those. That 15 minutes doesn't change for paper EMT purposes. It does change for what I think you should be doing in the field with your patients. Remember that their mental status is an excellent indicator of perfusion, and if that starts to deteriorate, we need to treat that, and we need to constantly be looking for signs and symptoms of development of shock. Interventions, supportive care, monitoring, maybe a little bit of, for a mild reaction, remove the stinger or clean the area of contact that caused the reaction, maybe put some ice on it, and could even include nasal O2 via nasal cannula, 2 liters per minute, and that's all you'd ever have to do. But if your patient is having an anaphylactic reaction, remember we had hives, we had angioedema, and we had wheezing. Those would be the cardinal 3. But if they have signs and symptoms of poor perfusion, they have signs and symptoms of poor perfusion coupled with dyspnea, we're treating them for respiratory failure. I keep saying that over and over because that kicks people's tails on the National Registry. As much as we talk about this, it blows my mind, but it does. And then transport to appropriate medical facility. Always reassess your interventions. Could take more than 1 injection of epinephrine. So consult medical control for any subsequent doses. That's good practice. You may have a protocol that allows you to administer up to 2 more if your patient begins to deteriorate again. Those are spaced every 5 minutes. Remember that. We don't ever give more than 3 total doses, and hopefully we're going to be with ALS or at the hospital by then. Signs and symptoms will return. As our patients metabolize epinephrine, it has a short half-life. That time half-life, remember that's when you hit that peak effectiveness with the medication, and then it starts to trail off as the body metabolizes it. So it have a really short half-life with epi. So watch for your patient to deteriorate again, the signs and symptoms to return. Documentation, always with anything, document signs and symptoms, why your interventions were indicated and how your patient then responded to the intervention. That's with any and all documentation. So what would you document if you gave epinephrine? What were the signs and symptoms that indicated the administration of epinephrine, and then the route of administration, the dosage in that administration, then your reassessment, how your patient responded to that treatment. That's what would be documented. Okay, we've talked about this the 3rd or 4th time now. If they're having a severe reaction, treat life threats, administer good BLS, get off that scene, rapid transport to the hospital, contact ALS to rendezvous with you on the way. That shows the stinger being removed with the credit card. Clean the area. Maybe your patient has a horrible reaction to poison ivy. A few people have no reaction to poison ivy. Maybe they have a horrible dermatological reaction, localized reaction to poison ivy. If you have soap and water available, then clean that with soap and water or some sort of antiseptic. Remember not to contaminate yourself. So we're using our PPE. You don't want to have poison ivy all over your arms and hands because you were dealing with somebody's poison ivy, and they have that old sticky, thick sap from poison ivy that causes their localized reaction. Here's one to remember and do it early on. And maybe all it takes, what I always did, say your patient they're having an allergic reaction that's causing swelling of their left arm. They have a wedding band and a watch and maybe even another ring on another finger. I always just moved it to the other side and told them I was doing it. And then I documented that I moved it to the other side. Why would I move that wedding band or that watch? Especially the wedding band. Watch you can usually get off. But rings, as fingers swell, it reaches the point that you can't get it off, and they have to use a ring cutter to cut it off. So if you move that to the other hand, then unless both hands are involved, you don't have that problem. When you remove jewelry or valuables from your patient, always document what you removed and what was done with it after you removed it. And if you turn it over to somebody at the hospital, make sure you get their name and you document that you delivered not just delivered patient's valuables to ER nurse. I would put the nurse's name and I would put a list of what those valuables were. That just protects you. You don't want to get fired for stealing because they believe your patient more than they believe you. So documentation could save your career. Maybe even keep you out of jail. Okay. Position the injection side of that bite below the level of the heart. Maybe we get a little bit of that venous pooling that keeps the part of that injected venom from making its way back into central circulation and causing a more extensive systemic problem. Apply ice or cold packs. What would that do? That decreases the rate of absorption of that venom or poison in that localized area where the bite or sting is. Always stay on top of the signs and symptoms of anaphylaxis. Position your patient appropriately. Signs and symptoms of shock, poor perfusion, we're going to get them in a shock position, which is supine. Provide oxygen as needed, including positive pressure ventilation, and we're going to monitor their vital signs. What does epinephrine do? And then we'll be wrapping this sucker up. Epinephrine mimics the hormone adrenaline that comes from the adrenal glands, and adrenaline is the sympathetic messenger hormone, sympathetic nervous system messenger hormone, or the messenger hormone of our sympathetic nervous system, which is what we call fight or flight. So we have pupillary constriction, bronchodilation, peripheral vasoconstriction, increased heart rate. So that's what we're doing with that epinephrine. So it is what? A sympathomimetic would be the class of the drug. And if we hear sympathomimetic as the class of a drug, we know that it triggers the sympathetic nervous system or that fight or flight response. All right. Has to be prescribed by a physician. Here's one that they love to trip you up with on the National Registry. You have two friends out hiking, and one of them has an EpiPen, the other doesn't. And your patient is having an anaphylactic reaction, and their friend hands you the EpiPen that's prescribed for friend and not patient. You cannot administer that epinephrine. online medical control could authorize you to give you an order to administer that epinephrine, but it takes order of a licensed physician to before you can administer that EpiPen. It could be that your service doesn't allow you to assist a patient in administering their epinephrine. I cannot imagine that, but you get out to the West Coast and they put handcuffs on you as far as patient care. So I guess almost anything's possible. Follow your protocols, consult online medical control. You have to paint a good verbal picture of your assessment of your patient and the indication for the administration of this medication, or you may not get the order and your patient may die from it. So you have to do a good job of assessing your patient, and then you have to do a good job of conveying your assessment findings to that physician in order to get approval to administer a medication. Don't lie to them. You get one shot at having a reputation, and you can blow your chance to care for a lot of patients by screwing up your reputation by lying to a doctor about the condition of your patient, just so you can perform a skill. I've seen it all too many times. I have been asleep in the supervisor's bunk at the station, and at 3:30 in the morning received a call from an ER doctor saying, "Do you know what the hell your paramedic just did?" "No, sir, but I bet I'm about to find out." Oh, man. That is a supervisor. That's a horrible call to receive. Okay. It may take up to 60 seconds or so for that epinephrine to be absorbed and begin having the therapeutic effects that your patient needs. Don't expect an instantaneous response. It might take a minute or so to absorb that medication, but it is relatively quickly with that EpiPen. Something we're going to tell you next week, and I'm going to tell you now because I don't want you to do this to yourself, but once you arm an EpiPen, or just don't ever touch the business end of this thing down here. This tip: if you inject yourself with that spring-loaded epi, you can lose a finger or a hand from it because it can cause vasoconstriction that lasts long enough so that you start having tissue necrosis from not perfusing that tissue in your finger or your hand. So it's not meant for fingers and hands. If that ever happens, call for ALS to get to you like right now, because it have to administer glucagon to counteract that. Side effects of epi: remember, it's a sympathomimetic. It mimics the action of the sympathetic nervous system, fight or flight. So elevated blood pressure, yes. Increased heart rate, yes. Anxiety, yes. It can cause your patient to have tachycardic cardiac rhythm. If they have an underlying cardiac condition, it may make them have funky heart rhythms. We don't have to worry about that here. We're going to worry about that in paramedic school, folks. All right. It's another reason to have an ALS unit if with an anaphylactic patient, because they do need to be on cardiac monitor as quickly as possible. Pallor because of peripheral vasoconstriction, dizziness, possibly chest pain, headache. They may tell you they feel like they feel their heart pounding in their head, or they can hear their heartbeat in their ears, all kinds of stuff like that. That's a side effect that goes with it. Nausea because of shunning blood away from the GI tract, vomiting, same reason. Abdominal cramps, same reason. If your patient doesn't have signs of respiratory compromise or hypotension, do not administer epi. That could trigger a hypertensive crisis. It could trigger a tachycardic event that causes your patient to have a bad cardiac event. So we don't administer it unless our patient has signs of respiratory compromise or hypotension. And all right, that is that chapter. I cannot think of another thing to add. Questions about any of that? I made it through. I thought I'd make it through this faster than that.